Thanks, Dr. Adams, for the introduction. I mean, basically, he summarizes the talk. So this is much less intellectual than the talk Nadi just gave. But it basically, I'm very happy that every one of our team actually is represented here from fellows, also perfusion, nurse practitioners, anesthesia, and that's actually the target audience for that specific talk. We know that blood conservation is a big issue in cardiac surgery. It has been seen in the last few years as a metric or a quality metric in cardiac surgery. And if you look at the current status, it's scary. If you look at the STS data, about half of the patient right now who gets cardiac surgery in the US gets transfused. And our data are pretty much almost consistent with the average, which is almost, a little less than 50% of our cabbages were getting transfused. And that has been sort of almost stable over the last few years, despite, repeated efforts to emphasize it. But we have never came up with a protocol that we all agree for, and we say, that's what we want to do, and we will track those cases afterward. So if you look, cardiac surgery consume at least 25% of the blood bank resources worldwide. And if you add trauma to cardiac surgery, that takes off at least 50% of the resources. So it's really important that we focus on, and it definitely has something to do with every single other metric that we look at cardiac surgery. So in other words, if we're working on ventilation time, we need to include blood conservation in it. ICU stay, wound infection, that's all part of the blood conservation. So I just want to stress that the goals of this blood conservation is not to avoid blood transfusion or just say that blood is bad. This is not absolutely never the message of that protocol. As a matter of fact, I'm highlighting the importance of treat anemia before heart surgery because we know that anemia has been associated with adverse outcomes in cardiac surgery. Again, that protocol will be specified for elective cases. We are not focusing on patients who are emergency or actively bleeding patients or Jehovah's Witness. And the last message that we stress on, this is a multimodality, multidiscipline. So in other words, the blood conservation starts from the time you see the patient, even before the patient comes to us, and until the patient goes home. If any cycle of that cascade gets interrupted, despite everything else, everyone else is doing a perfect job, we are not going to achieve blood conservation because, as you know, this is a very complex topic, a lot of things involved, and everyone basically sitting in this room can order a unit of blood for a patient today. If blood transfusion didn't happen in the OR because we did a very strict blood conservation on bypass, anesthesia, ICU still can transfuse the patient on the floor. So that's why that has to be seen as a discipline team sort of decision versus individual decision, as we all know that teams actually make better decisions in cardiac surgery than individual decisions. And if there is guidelines for blood conservation in cardiac surgery, the answer is yes. Over 10 years ago, the STS came up with these guidelines in 2007 and used whatever evidence available regarding blood conservation in the literature. And as a matter of fact, they updated it because new evidence came up about blood conservation in 2011. And this is a huge document. I would encourage all the fellows to read the STS guidelines because it's really interesting. And it entails a lot of measures that can be done pre, intra, or post-operative for cardiac surgical patients. And we all know that we are actually equipped enough with enough knowledge and technology that we can avoid transfusion or bring it down to zero. And I'm again reminding everyone that we take care of Jehovah's Witness in this program. Percy has been leading that initiative. Jehovah's Witness patients, they don't take blood transfusion. We do operate most of them, and we don't transfuse them. And there has been a tremendous amount of literature from Jehovah's Witness because those patients are actually the natural history of not transfusing patients, because unfortunately, the evidence is very hard to build in transfusion medicine. And the issue, because we cannot run a randomized trial for patient who bleeding or patient who needs blood, and we decide to give one patient blood and the others not, and then we compare both of them, because this is not a realistic randomized trial. However, the Jehovah's Witness patient gave us grimaces of that evidence. And I just got this, I found that paper, actually it was from Cleveland databases. They extracted about over 300 patients out of almost 90,000 patients. And they did propensity matched group of patients who are non-witnessed. And they found actually the Jehovah's Witnesses were not inferior in any of these acute outcome. As a matter of fact, they also looked at long-term outcomes for these patients. But you see, even respiratory failure, intubation time, ICU, and hospital stay were shortened in these patients. So what should we learn from that? We learn from even the most extreme form of blood conservation in Jehovah's Witness patient did not increase the mortality in those group of patients. And this is very interesting finding. Again, what does this tell me? It tells me, again, that a big portion of the blood conservation is a culture change, because once I see a Jehovah's Witness patient today in the clinic, I'm morally and legally committed not to transfuse the patient. And every time we do phlebotomy for this patient, we'll think twice, do the patient really needs that or not? If we can transfer that culture to the regular cardiac surgical patient, I don't think we will eliminate transfusion, because this is not the goal, but at least we can make good decisions in terms of who we should transfuse and who we should not. The central message of the STS guidelines is identifying high-risk patient for transfusion, because he said those are the patients who actually benefit most from blood conservation. And I have separated, they identified several risk factors. I mean, logically, you can tell that every one of these risk factors are a risk for transfusion. The most important that we should all focus on, patient who already comes to us, elective cases, could be a class 2 indication for surgery, whatever surgery you're doing, and they have a small preoperative RBCs volume. And those are, by definition, patients with preoperative anemia or a small BSA. Because if you expose these patients to the standard of care, what we're doing right now, we are transfusing most of these patients. And those are the low-hanging fruit that we actually can improve and protect those patients from transfusion. The other risk factors that the STS guidelines highlighted, including advanced age over 70, complex surgeries that require long bypass run, again, antiplatelet, antithrombotic treatment, emergency surgery, multiple comorbidities. As you can see, I've separated those high risk because those are high-risk patients. Those patients are most probably gonna transfuse, and if you do transfusion, it might be not a bad idea, because you're still gonna need to transfuse patients in cardiac surgery, and our goal, or the goal of the protocol, is to isolate the low risk patient who might be a good candidate for the protocol. And again, I'm stressing on that this is a multidisciplinary protocol, includes pre-op, perfusion, anesthesia, surgery, ICU, and post-operative care. The evidence came from the STS guidelines as individual protocols don't work. It has to be collaborative protocols, including all these areas. So I'm not going to go too granular in these measures that we can do for patient, but at least we can have a quick overlook of the STS guidelines, or the guidelines we want to implement here. What are the preoperative measures that you can do? First, we have to identify anemia, and the definition of anemia for males less than 13 and females less than 12 gram. Yesterday, I requested from Dr. Swain and her group to give us the information regarding how many of our elective cases actually come to us with anemia. Because what we need to do, we need to screen the patients. When we see the patient in the clinic, like the nurse practitioner usually gets information about the patient even before the patient comes physically to our clinic. We have to look at the BSA of the patient and the hematocrit. And if we think that this patient is anemic, that's what that target or get labeled as a blood conservation patient, or patient at risk for transfusion, just like as you calculate the STS for every patient. We will developing the anemia clinic with Dr. Cromwell. She's a hematologist who's actually interested to work with us in blood conservation, and have already designed algorithm for the Jehovah's Witness patient, which we will modify for our group of patients too. We want to restrict the hematology referral, because this basically will delay surgeries and just a lot of unnecessary logistics, only for patients who already have hematological diagnosis of a disorder like sickle cell disease or myeloproliferative CLL, whatever, and patients with significant or severe anemia. Those are the ones who were actually referred to hematology for clearance before surgery. The preoperative antiplatelet and antithrombotic, also we need to discuss among us as surgeons when to stop this medication, because this is a big deal now. And finally, I just put this, like, this is not in the STS guidelines, but we rarely require a cardiac cath for elective valve cases now. If we see a patient today, we're going to see a few patients in the clinic, low-risk patient. I know the patient most probably doesn't have coronary disease. We do CT angiograms. And if we can request a radial access, that will be even better, because that will eliminate that part out of the proportion. And we know that blood, even a simple angiogram, diagnostic angiogram, patients still can significantly lose a big portion of their blood during the cath. And for a small patient, that can make a big difference in terms of transfusion. This is an algorithm. This is not what we're going to use, but again, that's what the bloodless program here at Mount Sinai have agreed for, and this is sort of EPIC triggered templates. But we know that the most common cause of anemia worldwide is iron deficiency anemia, and that is easy to treat, whether by oral or IV iron. And many times for elective cases, you can wait for a few weeks before surgery just to improve the red blood cell mass of the patients. Again, that has to be modified to fit our patients, including both the inpatient as well as the outpatient population. And as Robin said the last time, there are actually papers that came up showing the intravenous epogen for patients who are anemic before heart surgery. Even 1 week before surgery makes a difference in terms of transfusion requirements after surgery. The epogen needs few days to work, but still it can at least help you after in the post-operative period. And very important, the transfusion risk is dose dependent. So if you have to transfuse and you transfuse the unit, that's better than giving 2 units, but hopefully we can avoid it altogether if possible. What about perfusion-related interventions? I had a meeting with the perfusion and team and Ricardo last Friday. We sat almost for at least 2 hours to discuss everything. That again has to come up as a team between us, the surgeons and the anesthesia, to basically agree or disagree for every item of these specific perfusion-related technology. Very important that before we start a case, for the fellows, you have to know what is the lowest hematocrit accepted for every individual patient. And we would possibly all agree that for a low-risk patient, crit can drift down to 20, and some even said to 18. Nothing will happen because at the end of the case, you will eventually hemoconcentrate the patient. For high-risk patient, it is reasonable to keep the hematocrit at 25 on bypass as lowest, because if you read the literature again, there is a big portion of literature talking about the risk of stroke and multi-organ dysfunction because of severe hemodilution on bypass. So, as I said, we had some evidence from the Jehovah's Witness, but also from the pediatrics, because you know the minimized circuit starts in beads. They wanted to avoid transfusion and hemodilution, and now there is almost a consensus that you don't need to use a standard circuit for every patient, because you're gonna hemodilute small patients no matter what you do. And we have been working on basically designing a mini circuit for small patients with a small PSA. The perfusion team is working on it. They already did the model, and they ordered some of these few oxygenators that we're going to use. The total brine volume of the oxygenator is like almost 200 cc fluid. That oxygenator can flow up to 5 liters. I've seen surgeons using that oxygenator for 90 kilos, but here we can even go down to 60 or 50 kilos, whatever numbers we're going to agree for, but it's definitely a big part of our discussion about using a mini circuit. RAP, I think most of us doing that now. Immediately before we go on bypass, the anesthesiologist will support the hemodynamics, allowing the perfusions to basically retrograde prime the arterial as well as the venous line. We had a discussion, a patient had a patent foramen ovale. We have to be careful while we're doing venous, because if the vacuum is connected, you can create an air embolization. Conventional ultrafiltration, standard of care now in almost 100% of the cases. We have to agree on how much we should take from the hemofilter, because sometimes we see that patient comes dry to the OR, and the perfusion, if you overdo basically the ultrafiltration, eventually the patient can be hypoperfused on bypass with high lactate at the end of the case. Salvage of the blood, of the pump blood, there is different ways to do it. As per our discussions with the transfuse solutions when we came here, give as much as you can at the end of bypass. Just don't expose the blood cells to further circuits. Don't salvage the rest of the blood in the cell saver, because you basically take out all the coagulation factors. So there are 2 ways to do it. You either give all the blood back in the arterial line, or if there's just too much volume and the patient RV is not perfect, then you can hemofiltrate in the circuit. as you are off bypass, and then either give it to the anesthesia or put it in the arterial line again. Microplegia, we worked on it for a long time, and I guess most of us are using it now for every patient. Normothermia also, we see now every patient has a bear hugger, and we have to maintain normothermia post-bypass because hypothermia can be a risk factor for bleeding. Anesthesia, there are different, a lot of literature came from the anesthesiologists actually about blood conservation in cardiac surgery. Pre-bypass hemodilution is an important issue because if a patient comes to the OR with a borderline hematocrit, we have to know exactly what was the hematocrit coming into the room and what was the hematocrit right immediately before going in bypass, because that represents how much hemodilution happened during that time. And that time can be extended if you take a long time in taking a vein graft and plus the memory harvest, that still operative time that the patient needs to be supported hemodynamically. So acute normovolemic hemodilution, big data about it. I would say there is no evidence probably that it have anything to do with blood transfusion, but there is some evidence that actually decrease the bleeding. And the reason for that, because if you think about it, the patient who I can take some or 1 or 2 units of blood on the table before the surgery are the patient who actually have a high blood volume and good hematocrit. And logistically, those are patients that hard to get transfusion because they already have good blood volume and good RBC mass. But I would say why not to do it if we can actually develop a protocol and decide what are the contraindication or what are the indication for acute normovolemic hemodilution. Because as I said, individually it might not have an impact, but collaboratively with the whole protocol, it might actually do something for specific patients. The antifibrinolytic drugs.
There is data for high volume ANH, like 600 to 800 cc's from the Michigan State database, as opposed to low volume ANH, which didn't decrease transfusion. In their data set for the state of Michigan, it decreased transfusion rates for high volume ANH and bleeding.
Yeah, so again, we will discuss the evidence and the details, I think, because we have to individualize specific talks for every item of this, and then we will come up with a protocol that we all agree for. I'm just giving you this as again, general outline, but it tells you how comprehensive that protocol should be. The antifibrinolytic drugs used every day here, again, rarely we see patients going to the ICU with antifibrinolytic, however, it should be part of the protocol. The point of care testing is already in practice. Strict intraoperative fluid balance, and that includes, priming volume for the bypass, pre-bypass, crystalloid, urine output, and etc. Surgical considerations. So meticulous surgery is the most important, I would say. Without meticulous surgery, there is no rule for blood conservation. If you do everything, patient have a surgical bleeding, patient will get transfused, he will have a redo for bleeding, the morbidity and mortality will escalate. So this is basically the rule number 1 in blood conservation. There is some evidence that topical sealing has been also linked recently to actually less bleeding, particularly in complex and fragile patients. However, every time you guys using a surgery cell or whatever local sealant, flow seal, whatever, there are associated risks with that. And we have to be thoughtful before we just decide to use any local topical sealant because we might not need it or actually expose the patient to the risk of it and plus the cost of the drug. The ICU care, again, this is a major leak for that blood conservation. Basically, I think Mahdi looked at how to limit the blood sampling and how much blood has been withdrawn from every patient after extubation. We have to limit the blood, basically blood letting of the patient post-extubation has to be protocolized. What about the transfusion triggers? Again, now we're talking about what we call a physiological transfusion triggers. We still have to stick to certain numbers so we can track the patients and get data. But I would say for low-risk patient, to be restrictive, high-risk patient, you can be a little bit more liberal because that's how we can protect our long-term, basically our O2E and our overall mortality. Because, again, I'm not defending blood conservation, but there are also people like there is a famous New England paper that came up a few years ago that showed that restrictive protocol was not superior or even harmful for high-risk patients. So we have to be careful when we implement blood conservation that there is a judgment element, and we have to definitely isolate low-risk from high-risk patients. MD approval for any transfusion has to be the standard of care. And Transfuse Solutions came up with transfusion algorithm that can be implemented for coagulopathy, whether it's in the OR or in the ICU. Thank you.